Okay, so this next section is autoimmune diseases, and I'm gonna try and do this in one video, so it might be a little bit longer. I'm gonna try and keep it under a half an hour. Here's the objectives. So the immune system, a couple key terms here. Self-tolerance recognizes the difference between self and foreign antigens. This ability is called immunologic tolerance. So usually the body knows itself and it knows what should be there and then what is a foreign antigen or something that shouldn't be in the body. And so it, keeps a pretty good defense and is able to differentiate. Autoimmunity, when innate mechanisms that normally prevent the immune system from attacking self-antigens fail. So all of a sudden something goes haywire, and instead of kind of protecting the body, it starts attacking the body. Activated T cells and antibodies begin to attack the individual's own tissue. Conditions associated with autoimmunity equal an autoimmune disease. So two primary factors needed to develop autoimmune diseases: inherited genes with increased susceptibility and contributing to failure of self-tolerance, and then environmental triggers initiate activation of autoantibodies such as an infection, fever, severe trauma. Autoimmune diseases often preceded by an infection. So something like if your grandfather has rheumatoid arthritis and your mother has type 1 diabetes, then the likelihood of you developing some kind of an autoimmune disease is increased. But then again, there's also tends to have to be an environmental trigger that initiates that activation. So autoimmune diseases, common characteristics, they're cluster of disorders presenting with more than one autoimmune disease, multi-system organ involvement, general signs and symptoms. Oftentimes there's fatigue, joint pain, muscle aches, sleep disorders, anemia, psychiatric difficulties such as depression, frustration, difficult finding a definitive diagnosis. I watched some videos trying to find a good video to post, but I really couldn't actually find a very good one. But I did listen to some interesting stories, people saying how it took 12 years to find a diagnosis, or, doctor after doctor after doctor, and just major frustration for trying to find a diagnosis. There's more than 100 different types of autoimmune diseases, and so just that alone obviously lets you know that with all those variations, it can be very tricky to find a diagnosis. So some examples of autoimmune diseases are adrenal insufficiency or Addison's disease, chronic fatigue syndrome. I'm not sure how to pronounce this one, but it's kind of an important one. Psychiatrical Pemphigoid. I'm going to look that up. Fibromyalgia, hyperthyroidism, hypothyroidism, multiple sclerosis, Myasthenias Gravis, Pemphigus vulgaris, pernicious anemia, psoriasis, rheumatoid arthritis, sclerodermia, Sjogren syndrome, and systemic lupus erythematosus. So medications used to treat autoimmune diseases are anti-inflammatory agents and then disease-modifying anti-rheumatic drugs, or DMARDs. There's NSAIDs and DMARDs. So in the anti-inflammatory agents, we have salicylates such as aspirin, and then there's NSAIDs, COX-2 inhibitors, corticosteroids, prednisone, and prednisolone. And then in the disease-modifying anti-rheumatic drugs, there's immune modulators, there's anti-cytokine therapies, anti-malarials, immune suppressants, and then there's penicillamine and gold compounds, so different categories. Management of autoimmune diseases typically include pharmacotherapy, beginning with anti-inflammatory medications and then progressing to immune suppressive drugs. The goal of the medication therapies used to treat autoimmune diseases is to reduce pain, improve the function, patient's function, slow the rate of the disease and the disease progression, and then limit tissue destruction. So, oral side effects of medication. Dental hygienists must be aware that the drugs used to treat autoimmune diseases produce numerous adverse effects, and patients may present with signs and symptoms that reflect their drug treatment and their diseases. So, each patient requires a comprehensive pharmacologic history review to determine the impact of the drug therapy on dental hygiene process of care. So, drugs like the salicylates, the NSAIDs, the COX-2 inhibitors, they're associated with adverse bleeding events, including bruising, gastrointestinal hemorrhaging, and then of course gingival bleeding is the one that we'd want to pay attention to. Lesions may occur on the oral mucosa, including the appearance of bluish-black pigmentation. Immunosuppressive drugs may cause gingival enlargement. So all of those things we need to be aware of with the side effects of the drugs that patients could be on. Complications with chronic use of corticosteroid medications include insomnia, peptic ulcerations, osteoporosis, cataract formation, glaucoma, growth suppression, delayed wound healing, psychosis, weight gain, adrenal insufficiency, and adrenal crisis. Patients undergoing chronic corticosteroid therapy are at risk for candidiasis, the most common oral side effect of these medications, which is related directly to their to the xerostomic effect of a lot of medications. So if they have xerostomia, they're at higher risk for candidiasis. They also may exhibit poor wound healing after dental hygiene therapy. Oral infections may be masked because of anti-inflammatory effects of these medications. So, they may not seem as inflamed as they actually are. Chronic dry mouth increases the risk for a variety of oral complications that require dental hygiene intervention. We know the chronic dry mouth with the increased caries risk and irritated oral mucosa. So dental hygiene care plan depends on the autoimmune disease and the diagnosis. Consider physical demands such as shorter appointments, assistive and supportive devices. We want to consult with the physician. We want to consider unusual oral complaints or manifestations, and then we want to consider the medications, the corticosteroids, the blood thinners, if they need pre-medication, and if they're on an immunosuppressant. Conditions to consider, oral manifestations. So common autoimmune disorders such as hypo and hyperthyroid, multiple sclerosis, Myasthenias Gravis, rheumatoid arthritis, Sjogren's, and systemic lupus all can have oral manifestations that we need to be aware of. So I made these charts to go through. I don't know that I want to read through all of it because you guys can do that. But these autoimmune diseases have very specific oral manifestations, and then these are the interventions. So go through these tables and become familiar with what we see, or at least have the names of these autoimmune diseases trigger a red flag that you'll want to look it up and see. What was that about this Psychiatrical Pemphigoid? There's vesicles that kind of reoccur and then rupture, leaving these areas of superficial ulcerated or denuded mucosa. Lesions are painful and may persist for weeks or months if untreated. And so there was some pictures in the textbook of these just super red areas after these vesicles ruptured. So consult the physician if difficulty with speaking or breathing. Treat the lesions with topical or systemic corticosteroids. Topical pain control for lesions. And there's a chart in the book that says what medications can be used for the topical pain control. And then protect eyes if ocular involvement. Fibromyalgia, temporal mandibular joint discomfort or dysfunction, pain in the face and head, and then xerostomia due to medications that they may be on. Hyperthyroidism, mild tremor in the tongue, osteoporosis in bones of the skull, axial and peripheral skeleton. Children can have premature loss of deciduous teeth with accelerated tooth eruption and faster development of the jaw. Adults can have marked loss of alveolar process, diffuse demineralization of the mandible, rapidly progressive periodontal disease, and then lingual thyroid tissue appears on the posterior dorsal region of the tongue, and then below areas of foramen cecum. So hypothyroidism in children, enlarged tongue, delayed eruption patterns, malocclusion in an adult, a hoarse voice, enlarged tongue, swelling of facial features. Multiple sclerosis, oral manifestation occurs in 2% to 3% of the population, so that's really not very high, but paresthesia, difficulty with speech, oral facial numbness, trigeminal neuralgia would be probably the biggest one, and drug-induced xerostomia actually might be even more common. So here's an image of multiple sclerosis. It's with that demyelination of the myelin sheath over the nerve fiber. So it just starts to deteriorate. Myasthenias gravis. I've had several patients with this autoimmune condition. Drooping eyelids and double vision. Muscular weakness in the face, head and neck, difficulty chewing, swallowing, difficulty wearing dentures, soft palate weakness, impaired lip movement, altered voice with nasal tone. So I had a male patient with myasthenias gravis, and then I had a female, and they both presented very differently. The male had this very distinct altered voice with a nasal tone, and he had a very weak feeling in his throat. He could not tolerate the ultrasonic at all, and so when he came in, I did all hand scaling. Sometimes he was worse off than others. Other times, the female patient tolerated the ultrasonic much better. She didn't have as much difficulty in the chewing and swallowing, or the soft palate weakness. She didn't have that as much, but she did have more vision issues, and she had better responses with her. They both were on corticosteroids, and she had better response to that. So my male patient seemed to have more severe symptoms than the female patient that I had, which was interesting. Pemphigus vulgaris, superficial ragged erosion and ulceration, haphazard distribution. Most common areas are in the palate, labial mucosa, buccal mucosa, ventral surface of the tongue, and gingiva. Pernicious anemia, painful red burning tongue with atrophy of the papilla, oral ulcerations. Psoriasis, oral manifestations are rare. Oral lesions appear as white or red plaques, mixed red and white lesions. Pustules, vesicles, or ulcerations. Geographic tongue may occur. Rheumatoid arthritis, TMJ involvement in almost 75% of the cases, limited or difficulty opening of the mouth, drug-induced gingival bleeding, drug-induced oral mucosa lesions. Scleroderma, radiographically widened periodontal ligament space, osseous destruction of the TMJ, mandibular angle, coronoid process, and the condyle. All of that can be visible radiographically. Jaw fractures late in the disease, microstomia, limited opening of the mouth, xerostomia, loss of attached gingival mucosa, and loss of attached gingiva, gingival mucosa, and generalized recession. Firm mobile tongue, difficulty with speech and swallowing, and anterior open bite. And there were some interesting images of the sclerodermia in the textbook as well. Sjogren syndrome, erythematous oral mucosa, enlarged salivary glands, especially the parotid gland, severe xerostomia, difficulty swallowing, altered taste, difficulty wearing dentures due to the xerostomia, fissured tongue, atrophy of papilla, candidiasis, and caries. Here's some images of Sjogren syndrome affecting the parotid gland, sublingual gland, submandibular glands. Dry eyes is another common symptom. Systemic lupus erythematous, oral lesions, 5 to 25% of patients. Location of lesions, the palate, buccal mucosa, gingiva. May appear lichenoid, may look nonspecific or I have the worst time pronouncing these words late at night. Ulceration, pain, erythema, hypokeratosis, xerostomia, taste alterations, oral mucosal pain, candidiasis, and periodontal disease. So there's a lot of manifestations for lupus. Chronic cutaneous lupus erythematous, painful lesions are particularly identical to lesions of erosive lycoplanus. So here's systemic lupus. You can see there's this mask, this kind of really red mask, the way it portrays itself. Adrenal insufficiency, Addison's disease or Cushing's disease. So chronic use of corticosteroids suppresses the body's own production and release of cortisol, resulting in secondary or medication-induced adrenal insufficiency. So a lot of times they'll alter how often they take the corticosteroid just so that your body doesn't shut off its own production of cortisol. The danger is that when the patient is physically and or psychologically stressed, the patient will not be able to produce an adequate amount of their own cortisol, also known as the stress responding, so it'll place him or her at risk of a decreased cardiac output, hypoglycemia, and circulatory shock. So adrenal crisis is very rare, but it's a life-threatening condition caused by acute adrenal suppression. So that's the fear, is that if the body has shut off its ability to produce cortisol, then when the patient needs it, when they're either, being stressed by something like surgery or anxiety or something like that, then they're not going to have it when they need it. And so that can lead to some really scary effects. So, all in all, the dental hygiene process of care, as always, we want to thoroughly assess the health history, the oral health, their pharmacology history. What are they taking for pharmacology? And then priorities. Is the oral health more important at the moment than something that's happening medically, or vice versa? And do we need to postpone dental hygiene care until the patient is stabilized and their condition is stabilized? Dental hygiene may aid in diagnosis of autoimmune disorders, especially if something is presenting itself with an oral manifestation of that condition. Autoimmune characteristics, we may be able to note those and then refer them as needed, and then considerations and modifications of dental hygiene treatment. So during the assessment phase, it is of utmost importance to obtain a thorough health, oral, and pharmacological history from the patient to identify conditions that warrant referral for medical evaluation. So the clinician must be able to determine if the need for medical care supersedes the need for oral care, whether it's safe to provide treatment, and what the patient will be able to tolerate in terms of appointment scheduling and procedures. Oral care may have to be deferred until additional medical evaluation and/or treatment is provided. So that just kind of goes into a little bit more detail than the slide here. So I posted this. I found this scale in an article, and then I just kind of recreated it in a tablet. But dental hygiene practitioners can measure oral health quality of life through two scales: the Modified Oral Health Impact Profile, which I did not look that one up, but I would like to actually compare the two, and then the Mouth Handicap in System Sclerosis Scale, which is what this one is. Comparisons can be made in a patient's quality of life using these assessments at different appointments and their autoimmune disease progression or treatment regimen changes. So as their autoimmune disease progresses or their medications are causing side effects, you can kind of compare it and see how things are being affected and progress. The dental hygiene student should determine those needs that can be improved through the delivery of dental hygiene intervention, and then identify referral needed for further dental care with and those within other healthcare disciplines based on the dental hygiene diagnosis. So we can ask them, things like, are you having difficulty opening your mouth? Are you having to avoid certain drinks? Do you have difficulty swallowing? My dentist has difficulties taking care of my teeth. So are you having difficulty getting your oral health care needs met? Is your dentition changing? Is something changing in your dentition? Are your lips retracted, or your cheeks more sunken? Things like that. So this is a scale that a patient can answer, never, rarely, occasionally, often, always, to help you kind of differentiate as their oral health changes during as their autoimmune disease progresses. So the autoimmune diseases are multifaceted, and they present challenges to general and oral healthcare professionals both. Given the nature of these diseases, patients may present with multiple needs that affect dental hygiene care. Using the dental hygiene process of care ensures adequate planning for the delivery of safe and comprehensive oral care. Consultation with the patient's physician may be necessary to complete the planning process to ensure patient safety. So, for example, a patient who presents with multiple sclerosis should be scheduled for treatments during periods of remission, and they may need steroid supplementation. Implementation includes the administration of dental hygiene intervention to minimize oral infection and restore oral health prevention, prevent future disease, and patient education. Patients must understand the relationship between their autoimmune condition, medical management, and oral care. Some patients may require further care with an oral specialist if mucosal lesions are not responding to initial treatment protocol. Others may need more definitive periodontal treatment. In these instances, referral to an oral pathologist or an oral surgeon or a periodontist may be warranted. So, to kind of revisit those thoughts, our goal is to minimize their infection and to restore their health and to educate them. So we may need to balance what we want to get done with what they can tolerate and what we can do. And we may need to just schedule our times of when we see our patients for when their disease is in remission or they're not having a flare-up. Patients need to understand the relationship between their condition, how they're medically managing it, and then the oral care. So how their autoimmune disease presents itself in the oral cavity, and then how their medication affects the oral cavity. Because that might even be a bigger issue, is that their medication is having some oral manifestation. And then specialists, is a specialist needed? Is something happening where they actually need to see a pathologist and have something biopsied, or see an oral surgeon or a periodontist? And then we want to recommend appropriate products. And then I want to revisit this topical pain control. Earlier, when we were talking about oral manifestations from some autoimmune conditions, it said we may recommend topical pain control. Well, if you look in box 53-7 in your 5th edition or box 48-4 in the 4th edition, it outlines that. So make sure you look at those in the textbook. And then patients' oral self-examination, making sure they are looking in their mouth to evaluate for dry mouth, lesions, or anything that is different or has changed in their oral cavity. And then it might be imperative or appropriate to see them on a more frequent basis, but of course that's going to depend on flare-ups of their condition or how their condition affects their overall health. We want to document progression and changes that we see, how their disease is progressing, and if their overall health is deteriorating or if their oral health is deteriorating. And then if we recommend something, we want to see how they do with it and the oral health outcomes. So we want to make sure that we document at every appointment how their overall health and oral health is coming along. And then here I just made this summary of oral health products and indications. And this goes, I could put this in every PowerPoint for every special need, because this is just something we need to know, backwards and forwards. And it's pretty much routine. Fluoride, what it's for; non-fluoride, what they're for; xylitol, what it is indicated for, and all of the rest of this. So this is a table that we're very familiar with.